Good evening, members. Good evening, everybody.
Yes, good evening to you.
Thank you. I can see that you can hear me clearly. Welcome to this talk, which will be given by our very own Dr. James Kigera, who's a lecturer in orthopedics, and is also a recent graduate in PhD. So we are esteemed to have him give his first talk after getting his PhD, and we hope he's going to give us a talk about and take us through this common problem of VTE problems, as we all come across it in our day-to-day life. I hope the slides are being put up. Kigera, are you ready, or we give you a few more minutes?
Thanks, Tom. I think I'm ready. Let me see if the sharing works. Let me know if you can see the slides.
Yes, I can see them.
Okay, thanks.
Okay.
Thanks, Dr. Mogire, for the introduction, and thanks to Kenya Orthopedic Association for asking me to give this talk. As you've heard, my name is Kigera. I'm an orthopedic surgeon and a member of the Kenya Orthopedic Association. Thanks to Sanofi, who have sponsored this talk, and they have been a good sponsor of the association over the years, and I'm sure later on they will tell us some story about what it is they market. So when I was asked to make this talk, I struggled a little bit, but because it's such a common thing, and we are all doing some form of prophylaxis as we do our practice. I thought to look at the burden of the issue, then have a look at what the guidelines are telling us, and then also look at some of the risk factors, how we evaluate our patients, and then later on, specific clinical scenarios that might be relevant to all of us as orthopedic surgeons. So I hope you will join me in this journey. So how big is the issue? Well, most of the data we have, it relates, especially in orthopedics, relates to arthroplasty, and it's estimated about between 1.6 and 2.5 of all arthroplasty cases would develop some form of venous thromboembolism. However, because of the changes in practice over the last decade or decade and a half, then these rates are on the decline. We ambulate our patients early. We do not take too long in theater. We try and use neuroaxial anesthesia. And all these have contributed to a decline in the condition. Our patients are also fitter than they were in the past. And this generally has contributed to a decline. However, when we look at the situation in Africa, while our rates are probably slightly higher than what we are seeing in other parts of the world, and we will look at why this is the case, it's estimated about a quarter of people who need prophylaxis are not getting it. And that is an indictment on us as clinicians. So what are the guidelines telling us? If we start further afield, we look at the NICE guidelines. These are from the United Kingdom. Basically, they conclude that we need to assess our patients as soon as we get a chance, weigh the benefits of prophylaxis vis-a-vis the risks, and do a continuous reassessment of our patients when they're in hospital and even in the post-operative reviews. They also emphasize on the need to recognize any deep venous thrombosis that happens after you have discharged these patients, because some of those can progress and become pulmonary embolisms. When you look at the American College of Chest Physicians from the US, they generally want to lean on the use of low molecular weight heparins as the main medication. As we come closer home, when we look at the South African Society for Thrombosis and Hemostasis, again, they seem to favor the use of low molecular weight heparins for prophylaxis, and they urge the need to recognize risk factors. Even much closer home, the Ministry of Health has got guidelines for the management of cardiovascular diseases, under which venous thromboembolism falls. Basically, the guidelines are saying we should identify risk factors and initiate chemothromboprophylaxis. And they give 3 preferred molecules. They also say that we can use mechanical if we do not have access to pharmacological means. This is a little bit different from what others are saying, where they say you want to start with the mechanical. When we get guidelines that are closer to what we practice in orthopedics, we look at guidelines from the American Academy of Orthopedic Surgeons. And more recently, the International Consensus Meeting on Venous Thromboembolism in Orthopedics. This was a meeting that used the Delphi technique and started in 2019, progressing through the pandemic. And I think we released this in 2021. And the results have been published in most orthopedic journals, including the JBJS, the American edition. In conclusion, what they say is we need to assess our patients. Any patients who have had a previous VTE, this is a red flag. The risk of bleeding is not something we can ignore, and they advocate for the use of chemothromboprophylaxis and only use mechanical if we think it's a very high-risk patient. Of course, they advocate the use of neuroaxial anesthesia, and this has been shown to reduce the risk, and also early mobilization, which is something that is being hammered a lot in orthopedics. So, who is at risk? What are the risk factors? What increases your risk? Some of the risk factors that have been identified, maybe some that we are aware of, and probably some that we may not be considering on a daily basis. Hypoalbuminemia is one of the risk factors that I'm not sure we look out for in our patients, but has been shown to increase the risk for VTE. A high BMI and increasing age are risk factors that I think we are all aware of. Others include cancers, especially active adenocarcinomas, the hematologic malignancies, your lymphomas and leukemias, etc. And any patients who are on hormonal management for cancer, whether this is especially common in breast and prostate CA. So those are at a definitely higher risk. Blood dyscrasias are also counted high up there. Renal dysfunction, chronic kidney disease is a risk factor, as is HIV. Sub-Saharan Africa has probably some of the higher rates of HIV, and this is something we should consider whenever we are evaluating our patients. Some other risk factors that have been identified include active sepsis. This is something that may happen in trauma, for example. So if a patient has active sepsis and they need to undergo some form of orthopedic surgery, those will be at a very high risk. Varicose veins, that is something that has been identified, and you should look for it even amongst our elective patients. Travel, especially air travel, long haul, defined as anything above 6 hours, whether this happens pre-operatively or immediately post-operatively, for those of you who may attend to patients who are either tourists or expatriates and who may want to go recuperate at home after the surgery, you should consider that this may raise the risk for venous thromboembolism. There is a direct correlation between the time you spend in surgery and also blood loss and VTE. So with increase in the time you take in theater, with increase in blood loss, and also with transfusion, this has been shown to increase the risk of VTE. The use of oral contraceptives amongst women of reproductive age is somewhat controversial, because while it does confer a risk, the risk is generally low because most of the people who use this have got other mitigating factors, including young age and probably an active lifestyle. When we look at the genetics, there are the 5 classical genetic abnormalities that have been shown to increase the risk for VTE. These include the hereditary antithrombin deficiency, protein C, protein S. This is something that we've learned since your days in pathology in undergraduate, factor V Leiden, and prothrombin mutation. More recently, it has been shown that people who have a non-blood or blood group also are at a slightly higher risk than those that have blood group O. Fibrinogen gamma mutations and hyper homocystinemia are also other mutations that can confer an increased risk in developing VTE. So these are patients then you would want to be more aggressive in your prophylaxis of VTE. There are certain risk factors that seem to be unique to us in the African continent. Some genetic mutations like the PROS1 and the V510M. Sickle cell trait, which is something that is common in the western part of Africa and also in East Africa, especially around the lake region. The trait and not the disease seems to confer a risk in venous thromboembolism. while we do know that increasing age is a risk factor, it's increasingly clear that young Africans and young African Americans have been shown to have risks that are higher than their contemporaries of other races. It's estimated about 46% of pulmonary embolisms are actually in people less than 40 years. So we probably should be a bit more vigilant, even amongst the younger people in Africa. Another interesting thing, which is something that we have studied even at Chiromo, is that a good number of Africans have got popliteal veins that have no valves. And we do know what these valves usually would do is to break up the column of blood as it finds its way back to the right side of the heart. The absence of those valves has been linked with an increase in the risk for venous thromboembolism. So when we look at our population here in the continent, then we probably need to be aware of the uniqueness of our patients. So many risk factors. It's difficult to remember them all when you have a patient in front of you. And so certain organizations have tried to make this easy for us by having methods in which we can evaluate our patients. And there are a couple of systems out there. The Caprini and the Padua are probably some of the more common ones. And what they try to do is to quantify the risk of VTE so that you can know whether you are erring on the side of chemothromoprophylaxis, or you need mechanical, or just the usual early ambulation would suffice. The risk factors should be balanced against the risk for bleeding, which is the single most important complication that arises from chemothromoprophylaxis. So this is an example of the Padua score, and we can see the points that are being given, and this tends to give you an idea of what they think were the risk factors. Someone who's critically ill, the inflammatory bowel disease, active cancer, etc. And we can see BMI and ongoing hormonal treatment way down there. When we look at the Caprini, again, similar kind of things. You can see age is way up there. BMI is also a factor, and then a few other things, including oral contraceptives, pregnancy, and stillbirths. Now, when you look at these systems, they might not be that useful to try and assess risk, especially in procedures that are not arthroplasty. And then the number of risk factors that they are evaluating are quite few, and we have just seen that probably there is more to consider. So the ideal scoring system, and we do not have one, needs to be derived from the new data, especially the changes that have happened in practice of late. The use of, for example, outpatient arthroplasty, something that probably didn't exist 20 or 30 years ago. The early ambulation that we now do for all our patients. A lot of the guidelines that are being used in orthopedics have a bias toward arthroplasty. And we do know that not all orthopedics is arthroplasty, and we probably need procedure-specific scoring so that we are able to look at specific procedures and ask ourselves, what are the risk factors for this one? The guidelines also probably need to take into account some modifiable risk factors. For example, if you're doing a unilateral surgery versus a bilateral surgery, definitely the risk needs to be different. The type of anesthesia that we are going to use, we have already seen that neuroaxial anesthesia confers some benefit, and general anesthesia probably increases the risk. These are things that need to come out in the guidelines that and the scoring systems that would be ideal. They also need to be interactive and easy to use. If they can be in an app or something like that, that would be brilliant. But also, these systems need to be able to predict two common things that happen in orthopedics: bleeding and wound complications, probably wound complications more than bleeding. The other challenge with scoring systems is the tendency to overgeneralize, and they lump up all the outcomes into one. And we do know there is a difference between a distal DVT, a proximal DVT, and a pulmonary embolism. And probably we are more concerned the closer we are to a pulmonary embolism, and probably not overly concerned with distal DVTs. We do know that the risk of a distal DVT, say below the knee level, the risk of that progressing into a PE is low. And they probably would need to be validated in different geographical regions and also for certain subspecialties. So we've seen the guidelines, we've seen the risk factors, we've seen the scoring systems, and maybe they're not ideal. You have a patient in front of you. What drug do you choose? And probably the thing to ask yourself is, what are the benefits versus the risk? We know the benefits. Let us try and figure out what are some of the risks of the different molecules out there. Heparin, the biggest challenge with heparin has been thrombocytopenia. Rates have been reported as high as 3, sometimes 4%. And this can persist in some patients, and it can be quite bothersome. The new oral anticoagulants, the biggest issue there is bleeding. And that is why low molecular heparins are probably the inpatient drug of choice, especially in orthopedics. At the time of discharge, there is probably some debate as to whether or not you want people to go home with injectables or you want to give them some oral anticoagulants. The Americans have got a liking for aspirin, and when you look at the studies that come from that part of the world, especially in young patients undergoing elective arthroplasty, and most of it being done in ambulatory care as opposed to inpatient care, there is a big tendency to want to use aspirin, and they have shown some pretty good results at their end. If your patient does develop a bleeding, it might be important to know what would be the antidote. And that table tries to give you an idea of the antidote, what it works against, how common it is to find it, and an idea as to cost. Of course, these costs are probably North American costs, and they may not exactly be related to what we have here in the continent or in the country. The common drugs we have with us, platelet inhibitors, then either you transfuse platelets or use desmopressin. Protamine is useful with unfractionated heparin, and a little bit less with low molecular heparinoids. And probably for those you would need siraparatang, and that is something that is probably not commercially available. So probably what you would be left with would be protamine. The vitamin K antagonists have got their antidotes as well. So do the factor 10A inhibitors. So let's look at some specific scenarios, and then let's see whether or not we can find something that we can discuss in terms of what we do with specific patients. I think for arthroplasty, this has probably been well established in most jurisdictions that the use of neuroaxial anesthesia, especially for lower limb arthroplasty, your hip, knee, ankle, etc., is definitely a good idea for those patients who qualify for that. And you probably want to begin your chemothromboprophylaxis 6 to 12 hours post-operatively. And you want to have a bias towards low molecular weight heparins. Like I mentioned, the Americans fancy the use of aspirin, and now there is definitely an increase in the use of the new oral anticoagulants. So trauma. So I think in trauma, we probably need to categorize your patient into either having a major risk or a minor risk for a VTE episode. And in terms of pathology or the anatomical area where the injuries are at, if they are from the ankle and proximal, so that's your ankle, tibia, knee, femur, pelvis, then the risk is high and the use of low molecular weight heparins is advised. Some studies suggest that it probably does not reduce the risk of PE or mortality, but probably reduces DVT, but still, if the fracture is a proximal one, VTE is advised when you look at the ICME guidelines. For those that are non-major, these are your upper limb injuries and injuries that are distal to the ankle, or a single lower limb injury, or probably where you're using casting. Here you would need to weigh your risks vis-a-vis the benefits. So if you have an obese patient who has previous DVT or PE, even with your upper limb or single lower limb injuries, then you probably would want to consider the use of chemothromboeprophylaxis. Hip fractures are an especially interesting entity because even the hip fractures that you decide not to operate, it is advised that you initiate thromboprophylaxis as soon as you see these patients, and probably extend that up to a period of 28 days. The confounding factor here is age. The majority of your patients who are suffering hip fractures from simple falls are probably elderly, osteoporotic, and hence the need to be a little bit more aggressive when you consider thromboprophylaxis. If for any reason you need to delay surgery and hence you start to use pre-op thromboprophylaxis, you need to be cognizant of the half-life of the medication that you're going to use. And I will show you some guidelines later on what might be a useful time to stop the prophylaxis before you consider surgery to mitigate the risk of bleeding and epidural hematomas. So it looks like if you delay your surgery by about 2 days, then the risk of VTE rises to more than half. So it would be unimaginable that you do not want to consider thromboprophylaxis in this group of patients. Spine surgery is one of those where you would want to bring all your training into consideration. So high-risk spine surgery can be defined either as a result of the indication. So if you're doing spine surgery for oncology, or for adult trauma or for infection, that is high risk. Some approaches are more high risk than others. If you need to do a combined anterior-posterior approach, if you're going to use anterior lumbar and posterior cervical, these approaches are considered high risk as far as VTE is concerned. If the surgery is complex, and some of the factors that can guide you to its complexity are the need for postoperative intensive care, if you have multiple levels, multiple stages in terms of staged surgery, long segments, then this would be a high-risk patient. It has also been shown that patients who suffer dural tears intra-op, then these are also patients who are at high risk for VTE and hence should be treated as such. Some of the low-risk spine cases would be those that are elective in children, and certain procedures like microdiscectomies, anterior cervical fusions, and decompressions that may not involve instrumentation. In these ones, then you may need to just weigh the risk versus benefit, and you can individualize the care for your patient. Now, if your spine patient was using some form of prophylaxis for probably a different condition pre-op, then you need to consider stopping these chemicals before the surgery. And the recommendation is about 1 to 3 days for aspirin and other antiplatelets, and for warfarin and vitamin K antagonists, about 5 days. This is to try and mitigate the risk of wound complications, bleeding, and epidural hematomas, which can be devastating. Postoperatively, the guidelines seem to suggest somewhere between 24 and 48 hours. So not as early as your arthroplasty or your hip fracture patients. And this again is to try and mitigate the risk of bleeding and epidural hematomas from development. So foot and ankle generally may be low risk. Ankle fractures are somewhere at the border, and some guidelines would indicate that you would want to consider prophylaxis for those. But anything distal to that may not need any chemo thromboprophylaxis. Achilles tendon surgery, whether it is a repair or turn downs or grafting or lengthening etc., in the adult, this may confer a specific increased risk, and this may be one of those cases where you'd want to consider chemo thromboprophylaxis. For arthroscopy, the risk is very low, and probably no clinical benefit in considering chemo thromboprophylaxis for these patients if it's an isolated arthroscopic procedure. However, some critics may argue that probably the risk and the burden is underreported, but definitely the risk here is pretty low. And these are patients who you can consider either your stockings, your early ambulation, etc. Maybe if you are extremely paranoid, maybe the use of aspirin. Limb immobilization controversial because we do know that that immobilization may confer a risk as far as VTE is concerned. So when you look at the ICME guidelines, they seem to suggest you do not need to use any chemothromboprophylaxis. And even when you do, it looks like you just reduce the risk of DVT, probably not PE. And hence, this is one of those cases where you are assess the risk factors for your patients and the benefits that the prophylaxis would confer. Although we've mentioned this when it's specific to spine surgery, when it comes to other orthopedic surgeries, it's unclear whether we need to stop your antiplatelets. So you may have these patients who are being managed for a physician for a cardiac condition, and they have been given junior aspirin or dabigatran or some other form of medication there. There's probably no need to stop this for other orthopedic surgery other than spine surgery. There's probably no benefit. However, if they are using your warfarin or your NOACs, then you do need to stop, and you do not need to convert them to your unfractionated heparin or your low molecular weight heparin in the interim because of the risk of bleeding. So you stop and then you start your surgery at the expiry of the time period without the need for an intervening injectable anticoagulant. What are some of the other concerns you may have as an orthopedic surgeon? Does tourniquet increase the risk of VTE in your patients? There doesn't seem to be any risk. The use of tranexamic acid, this has especially become very popular for arthroplasty and sometimes for complex trauma. Again, you can use that without thinking that you are increasing the risk for VTE in your patient. Now, the use of bone cement has long been thought to be to confer a risk factor. However, when they looked at the data, they could only find an increase in the risk in spine cases, especially where they were trying to do kyphoplasty. And the reasoning here is that the bone cement can embolize and form a focus, which will then create a clot that can propagate. Generally speaking, for all your orthopedic patients, the highest risk of a VTE occurring is in the first month. And hence, generally, that is about how long you would need to anticoagulate your patients with a certain level of comfort. So your patients have a DVT and you're considering an elective surgery. How long do you wait? If it's elective, this is proposed to be somewhere around 6 months. It's important sometimes to consult our interventional cardiology colleagues. If you have patients who you think are high risk, cannot get chemothromboprophylaxis for whatever reason, then IVC filters are things to consider. Now, so sometimes you do a beautiful surgery, and then a day or so later, you look at the dressing and it's oozing a little bit, and then you're beginning to panic. But when you open, you find it looks serous, especially when you've done like an arthroplasty. So if you notice this, then, and you have been using chemothromboprophylaxis, you can be advised to stop the thromboprophylaxis. This is especially true if you are using one of the more aggressive methods, your new oral anticoagulants or your low molecular weight heparins or unfractionated heparin. And then you're advised to change to a less aggressive molecule. And this is where aspirin has got a big role. It has the lowest wound complication rate of all molecules that have been used for prophylaxis in our patients. So in conclusion, what are we saying? One is that guidelines exist. So the story of saying we do not have local guidelines might not suffice if you get caught. It's important to assess the individual risk of VTE for your patients. And we have looked at some genetic factors, some factors related to the diagnosis, related to premorbid conditions, related to the procedure that is going to be done, the approach, blood loss, need for transfusion, etc. Use those factors to determine whether your patient is at high risk. Remember, there's always a risk of bleeding, and one of the most devastating things that can happen is an epidural hematoma, because the few cases that have been reported have resulted in total paralysis. It's important to individualize care as we manage our patients. A sample of some of the references that I went through, Asanteni Sana. Back to you, Dr. Tom Mogere.
Thank you very much, James. That was very elucidative, and I think we've learned a lot. And I think point we'll invite questions so that we can be able to hear what people are going to give us. To start off, Dr. Kigera, I get a patient who is a polytrauma patient. He's broken pelvis, he has a femur, maybe a humerus, and maybe a bit of a chest injury. How soon will you start your prophylaxis?
Thanks, Dr. Mogere. So I think you will be guided by how soon you want to intervene surgically. If you are intervening within the first 6 to 12 hours of injury, you may not need to have pre-op thromboprophylaxis, and hence your prophylaxis would be post-op. However, if there are delays, like I know sometimes happens in some of our institutions, and you will need to go beyond that, you would need to have pre-op thromboprophylaxis, because then the risk of VTE rises once this patient has had that amount of trauma, is immobile within the first 12 hours, the risk begins to rise.
So are you saying you start within the first 12 hours, first 6 hours, or wait until after 24 hours?
So the risk rises from 12 hours. So again, individualize your care. So if it is BMI of 40 with other risk factors, previous CA, blah, blah, you probably want to start at the 12-hour period. If the risk factors are not as glaring, you can wait until your 24-hour period. There probably would be an opportunity for you to then consider, then if you're going to start operative management, the need to stop the thromboprophylaxis before you start surgery to reduce the risk of bleeding and epidural hematomas. So probably your molecule of choice would be something that has got a low half-life, and this is where your injectables are useful as opposed to using the orals.
Okay, thank you. Okay, we invite questions. Anybody who wants to shoot a question to Kigera? Kigera, now as we wait for the questions to come in, there was initially we heard there was that push for KOA to come up with a clear-cut prophylaxis for our area of practice. Have you any headway? Or do we have any?
Well, I am not aware that we've come up with any specific guidelines for our local situation. Maybe Dr. Chomba, if she's in the audience, can guide me. However, when you look at the work that was done by the ICME 2 or 3 years back, it was pretty exhaustive work. Probably the only thing we would need to add would be any specific unique risk factors that we have for our continent. And like you've mentioned, things like delays preoperatively, either for financial or logistical reasons, etc. But I think what they've done has been pretty exhaustive. But I guess Dr. Chomba and I think Dr. Ndeleva were spearheading some guidelines. I don't know whether we have adopted any.
Okay, there's a question from Samuel Wafula in the chat. Our some presentation noted increase in DVT cases in pediatric population with trauma, especially with infections. Any guidelines on the same?
Thanks, Dr. Wafula, for the question. So while being young confers a benefit of sorts, sepsis is a unique specific risk factor for VTE. So if you have a patient with active sepsis and requires an orthopedic surgery, you should weigh that against the other factors. But sepsis has been shown to be a unique risk factor, especially if those patients are going to then undergo an orthopedic surgery. So if patient has sepsis, then thromboprophylaxis is a good idea. This is especially for those patients you would consider borderline. So they're probably not 3 years old. They are, they're headed towards your 13, 14 age, and then so they are closer to an adult. They have probably major trauma, and then they have sepsis. Those are specific risk factors, and you should consider the use of thromboprophylaxis.
Another question from iPhone. For your arthroplasty patients, any advantage on using oral anticoagulants together with medical compression stockings?
So, some time back, there are certain centers where, everyone who goes into an orthopedic ward would have those interesting white stockings. And in some institutions, they'd also use intermittent compression devices, etc. What has come out over the years is that with the changes in how we're managing our patients, like I mentioned, early ambulation, use of neuroaxial anesthesia, there is probably no benefit for routinely combining chemothromboprophylaxis with the mechanical, unless it's a high-risk patient. So there's probably no additional benefit in combining those. Because of the compliance of patients, the use of the stocking sometimes doesn't work out very well. So if you're using oral anticoagulants, and these are probably what you'd call more aggressive than the injectables, there might be no role for the compression stockings unless it's an extremely high-risk patient.
Okay, I think that's clear. Let me see. There's another. Okay, another question for Collins Chirchir. It says, is prophylaxis also as necessary for hemiarthroplasty patients?
So that would be probably an easy question to answer. So the majority of your hemiarthroplasty patients are probably getting this for a fracture of the neck of femur. We have seen that fracture of the neck of femur is a uniquely high-risk situation. So it probably would be inconceivable that you would have a fractured neck of femur patient who then undergoes an arthroplasty, even if this is hemi, and doesn't get thromboprophylaxis. That would probably need to be justified either because of risk factors, etc., or they already have an IVC filter, etc. But I would advocate that all your hemiarthroplasty patients, especially if it is because of a fractured neck of femur, and by the time you're doing this, this is probably either an older patient, not much demanding, so probably mobility is an issue, then the use of thromboprophylaxis, hemothromboprophylaxis is advised.
Then there's another question from Abdul Rahim Wanika. In the last slides, you said cardio-targeting anticoagulants are not stopped when, then what is done to limit the risk of bleeding in serious orthopedic injuries, say in multiple trauma patients?
Good question. So the time when you are not concerned about the antiplatelet medications, which are given to these cardiac patients, is in elective arthroplasty. So for your aspirin ETC, for elective arthroplasty, there's probably no need to stop those if they were given for a cardiac reason. However, if you're talking about the NOACs, the new oral anticoagulants, or you're talking about the vitamin K antagonists, your warfarin, etc., those would need to be stopped. 2 days for the NOACs, 5 days for your warfarin. 5 days pre-op, 2 days pre-op for those cases.
I think I'm seeing no other question at this point. I think unless somebody wants to make a comment, I think we'll be coming to the end, and maybe we'll be inviting the sponsors to give their comments before we close and hear any messages from the KOA desk. Any comments? All right. I think having nobody ready to comment, I think we at this point will invite the sponsor Sanofi to give us a few comments, and then we'll hear any messages from KOA desk.
Okay, thank you very much, Dr. Tom, for that, and Dr. Mogire, and Dr. Kigera, sorry, for that wonderful presentation. My name is Purity Maina. I'm representing Sanofi today, and I'll be speaking about our product that is Clexane. Kindly let me know when you see my screen, please.
Not yet.
Just a moment, Doc. Just sharing in a few.
Oh yeah, I've seen something.
Please let me know once you can see it. I'll be very brief. Dr. Kigera has done quite a very good job in terms of discussing everything about VTE in orthopedics. Okay, so I'll kick off, and this is me again. And just as a reminder, I just want to talk about VTE safety zone, and we like making sure that our hospitals are VTE safety zones so that we can ensure that our patients do not develop DVT, which could lead up to a PE. The objectives of my presentation today is I would like to just remind about the understanding of the burden of VTE, to also emphasize on understanding on how to achieve adequate prophylaxis for our patients who are at risk of developing a DVT or even a PE, and also to remind about the injection technique. As Doc had already discussed earlier, that VTE is often silent in nature and it is difficult to diagnose, and therefore, and this is mostly seen due to the lack of routinely performed postmortems. This is because we only see 10 to 20% of the symptoms, while 80 to 90% are not usually seen. Therefore, in Sanofi, we recommend that VTE we recommend that the hospital should be able to use various tools, as Doc had discussed, to be able to quantify our patients on the risk of, if they are on a risk of developing a clot. VTE has been established to be a global burden, and as we can see from this study, the VTE study shows that deaths due to VTE based on postmortem are about 514,000, that is annually. And according to the ENDO study, which was done in 2008 by Lancet, it showed that the burden of VTE is quite high, and at least most of the patients, about 5 to 10% develop, do die, and this is because of PE, and most of them are usually hospitalized. So therefore, patients with VTE, we recommend that we established the prophylaxis methods, and this can be the Caprini or the Padua, depending on what suits you and what suits you. A good example here on the ENDO study, it shows that how it took place, and the primary objective and the number of patients that we had was around 68,000, 52 of which were at risk of developing VTE. And the secondary objective showed that 50% did not receive the recommended prophylaxis by ACCP guidelines. Of these patients, 64% of them were surgical patients, and only 59% received the recommended prophylaxis. Whereas in the medical end, we had 42% who were at risk, and only 40% of them received the appropriate prophylaxis. This showed that there is a need for the hospitals to use and incorporate hospital-wide strategies to be able to catch DVT early to prevent PEs. So, as we have said before, we can see that VTE is a major public health crisis, and we can see that most of our patients tend to develop even venous ulcers, and which tend to decrease their mobility, and therefore they require an ongoing nursing care. And this is usually the post-thrombotic syndrome. So if you join us with your hospitals, we would love, as Sanofi, we have a method. We usually use the Caprini method, and we encourage the hospitals to take up this method. And this will be a hospital-wide strategy that can be used from the A&D up to the wards to be able to systematically not only risk assess them, but to do so systematically. And therefore, we can be able to quantify our patients and be able to tell which require prophylaxis and to what end. And that is just as a discussion of what I've already explained. Moving on, the reason is why I'm here today is to talk about Clexane, the only biologic low molecular weight heparin that we have in the country, which has been proven to be predictable in protection and prevention of VTE. So how does Clexane work? Clexane works on the intrinsic and according to the intrinsic and the extrinsic pathway of coagulation cascade. Clexane works as a factor 10 inhibitor and also as a factor 2 inhibitor on a ratio of 3:1, and that is the action of Clexane. So focusing on all that, Clexane provides decades of clinical evidence, and this has been shown by various studies and trials. And this started in the 1987, where we had studies on DVT prophylaxis in hip and knee replacement surgeries, came down to abdominal surgery. We have it also in unstable angina and unQFMI for cardiology patients, in medically ill patients. And also, as of 2007, it has been approved for acute STEMI and management of PCI. So these are some of the studies that support our guidelines and what we recommend when you're using Clexane, either in medically ill patients or in surgery or even in cardiology patients. So how about in surgery? As Doc had already explained, I'll just do as a reminder on what dosage to give and the duration of treatment. So in this study, the Noxacan study, patients who are on this study, they were 40 years and above with a life expectancy of more than 6 months. They were to go either surgery of malignant tumors of the GI, genitourinary tract, or the female reproductive organs. The surgery was to last for more than 45 minutes under general anesthesia. So how was the randomization? It was based on an enoxaparin 40 mg and a placebo, and the placebo in this case was unfractionated heparin. The endpoints of the study was, the primary endpoint was a VTE if a patient developed VTE between 25 to 31 days. And the secondary endpoint was if there was bleeding within 3 weeks after randomization. So for your cancer patients, post-surgery, we recommend that these patients, that they do have Clexane for at least for 6 months, as cancer has been shown to have a 6-fold higher risk of developing VTE than in non-cancer patients. And it has been shown to be the second leading cause of death for patients with malignant disease. And as you can see on this graph, the risk relatively goes down on days 20, but the risk starts to go up again, even more, even after 30 days of treatment. So Clexane should be given for at least 28 days for your cancer patient post-surgery, but if in treatment, you should give it for at least 6 months. And those are the bodies that back up our data in everything that I've just discussed in terms of cancer surgery. So for the PD cases, as we have already discussed earlier, we recommend that Clexane should be given 40 mg once daily prophylaxis, and that should be initiated after 12 hours after surgery and should be stopped 12 hours before surgery. And this is according to the ACCP 2012 guidelines. And you should give it for at least 35 days. For your medically ill patients, these are your patients who have acute heart failure, respiratory failure, acute infectious disease with or without septic shock, rheumatic disorders, acute arthritis of the legs, or acute inflammatory bowel disease. As we have already seen that these are all high-risk patients who require prophylaxis. And according to the Medenox study, it showed that these patients require prophylaxis. And for your medically ill patients, you should give Clexane 40 mg once daily for up to between 6 to 14 days or until your patient is in full ambulation. In treatment, for your patients who already have DVT, we recommend that you give Clexane 1 mg per kg every 12 hours, that is BD, or you can give 1.5 mg per kg once daily for at least 10 days. For your cardiology patients, even if they are coming for orthopedic surgeries, we recommend that these patients should be on prophylaxis. For your patients with unstable angina, for STEMI patients, and even patients who are being managed by PCI before or after a balloon inflation, you need to put them on prophylaxis. And this is according to as shown below, as you can see. For your renal impaired patients, with a creatinine clearance of less than 30 ml per minute, we recommend that you give Clexane the 20 mg prophylaxis, and the dose now will be dependent in terms of if they have unstable angina or if they're STEMI patients. And finally, I won't discuss much. We have misconceptions about thromboprophylaxis, and one of these is that the rates of VTE have decreased over the years, and as we have seen, even in elective or other surgeries, is that the rate of prophylaxis and the need for prophylaxis has relatively increased due to our lifestyle and even due to more surgeries that have been ongoing. And does the risk for bleeding from anticoagulants outweigh the benefits of routine thromboprophylaxis? And data shows that the incidence of major bleeding differs between patients receiving low molecular weight heparin or unfractionated heparin to those given placebo. And for these patients, if they have a high risk of bleeding, we recommend that you can do the mechanical methods as an alternative. So these are guidelines. They base for your patients with a critically ill patients, you can do prophylaxis. And for your already diagnosed patients with DVT, we recommend that you can do the treatment doses. So why Clexane? Clexane is readily available with an already known antithrombotic effect. Clexane has a longer half-life and can be conveniently dosed either BD or OD, depending either is treatment or prophylaxis. Clexane has less binding to blood proteins, therefore we have less adverse effects such as bleeding. So there is no need for monitoring as well when you're using Clexane. And are all low molecular weight heparin the same? And this I will say no. And this is why, according to the ACCP guidelines, it recommends that because low molecular weight heparins are prepared in different methods of depolymerization, they differ up to some extent in their pharmacokinetic properties and therefore anticoagulant profiles. And therefore we recommend dosing regimens, which in each and every drug should be used differently, and the drugs are not interchangeable on unit per unit basis. And the drug, as I have said, is the process, and our manufacturing process is different from any other low molecular weight heparin. And these are some of the bodies that support our data. And how do we give Clexane? As we had already discussed, I won't repeat this again. These are the recommended doses. We have Clexane 40 for your prophylaxis, and the 20. We have 60 and 80 for your treatment doses. And in spinal anesthesia, as Doc had already discussed before, in the context of an epidural or a spinal anesthesia, we recommend that you show extreme vigilance when you're giving it to prevent, and also you should watch to prevent any neurological impairment. This is how Clexane looks like. We have the 20, it is color-coded, 20 being white. Clexane 40 comes in yellow, and Clexane 60 comes in orange. Clexane 80 comes in brown. And that is it. Thank you very much. That is just as a reminder on the how to do the injection technique. We need to make a pinch and inject at a 90 degrees angle, let the drug go in and never dispense the air bubble, and then we release, and no rubbing on the injection site to prevent hematomas. And thank you very much for your time. Back to you, Dr. Tom.
Thank you very much, Jerry, for that good reminder on Clexane, old drug which work. Any questions from Jerry? Any questions? I think Paul understood you clearly. Any announcement from the KOA desk?
Thank you all. Mine only is to remind the participants who require CPD points to share their contact details to the number I've shared in the chat.
Okay, thank you. I think we'll call it an evening until we see you next time. Thank you, everybody.
Thank you.